Welcome in, guys. Happy Friday Eve, guys. We're going to talk all things medical coding in here. Let me turn this down. Welcome in, everyone. We're going to talk all things medical coding in here. I am Coach Tosh, your medical coding bestie. Welcome in, guys. Welcome in. We're going to get started in 1 minute, everyone. Welcome in, everyone. Welcome in. Welcome in, guys. Welcome in, guys. Grab your daily heartbeat. We're going to start in about 1 more minute, guys. Hope everyone's had a great Thursday. Can't believe it's the end of the week. Welcome in, guys. Welcome in. You ready for class? Good, Big Nova. Welcome in. Guys, can y'all believe it's Thursday? I cannot. Well, welcome in, guys. Happy Thursday. Hope you all had a great day today. I am Coach Tosh, your inpatient medical coding bestie. Welcome in, Ambassador. We talk all things medical coding in here as it relates to inpatient medical coding, guys. I'll give a few more minutes to, tap and like the live, guys, so more of our besties can come in. I will be teaching a little tonight. Nothing heavy, right? I think we're going to go over, I'm going to ask you guys some questions, right, for my day ones, and then we'll go over some of the medical coding conventions, all right? If you are new in here, my name is Coach Tosh. I have been in the medical coding industry for over 25 years now, all right? That may seem like a long time, but it goes by very, very fast, guys. Let me tell you guys what I've done in my profession really, really quick, because I know you guys have enjoyed to hear all about me, but for me to tell you all about this wonderful profession that is a skill you can learn, you can earn good money, and you can work from home, okay? I started over 25 years ago as an inpatient coder. I've primarily done inpatient coding. Why? The money is phenomenal on the inpatient side, okay? And it still does not require a degree, guys. I have held one inpatient coding credential, that is the CCS. So we'll talk about these coding credentials. There are many that's floating around that really honestly don't mean a thing in the coding arena, okay? There is two legs to medical coding. There is inpatient, all right, as it relates to inpatient, outpatient, as it relates to ambulatory surgery, which is like a kick or spin off from an acute care facility, okay? And then we have physician office coding. Hey Tammy, welcome in guys. Grab you guys daily heart meat while we're getting warmed up here. So, okay, like I said, all right, so I've been in the profession for a long time, guys, all right? So you can kind of trust what Coach Tosh is putting down in this live, all right, or on the platform. Inpatient medical coding. What is medical coding, guys? Medical coding is the translation of diagnoses into alphanumeric codes. Why do we translate diagnosis into alphanumeric codes, all right? Hell, I don't know. No, honestly, I do know. However, I want you guys to know that it is the reimbursement system, all right? When we talk about systems, we like to think systemic, big, right? So the government International Classification of Diseases has said in order for anyone to get paid in the healthcare arena, all right, those diagnoses have to, okay, be translated into alphanumeric codes before that chart or that account can go to the insurance company. So long story short, medical coding is a viable profession, and this is what we talk about on the live. But I go into specifically as it relates to inpatient coding, and I touch on another, I'm going to say hot topic, but has moved into the arena of inpatient coding, and that is CDI, Clinical Documentation Improvement. That kind of paves the way for our nurses that maybe want to broaden your skills, your clinical skills, and move into another part of healthcare, okay, that pays very well. So I always like to start, okay, so you guys know what coding is. Welcome in, Fee. Hey, so you guys, okay, we know what medical coding is, why we do it, okay? Let's talk about the credentials, all right? It's two legs, inpatient coding and outpatient coding. All credentials are not the same, all right? All credentials are not the same. Let me repeat that. Welcome in, Lolly. Credentials are not the same. We have physician office credentials, and then we have inpatient, outpatient coding credentials, okay? Inpatient coding credentials will qualify you to code in an inpatient hospital, right? Or an ambulatory surgery center, or which is a spinoff from the acute care facility. Okay, when I talk about inpatient, I have to be mindful that these terms may be new to some. An inpatient hospital is one, if you've ever had surgery and spent the night, if you've ever delivered a baby and you had to stay in the hospital overnight, that is considered inpatient hospital, okay? As it relates to coding, that's where inpatient medical coders reside, okay? Not physically, guys. We have been I'm saying fortunate because it does create a lot of work-life balance, right? The career is primarily a work from home career now. All right, so that's inpatient coding. Outpatient, as it relates to physician, okay? Now, outpatient is anything where you're not spending more than 24 hours, okay, in a hospital setting, spending the night waking up. So that would include when you go to the doctor, that's outpatient. When you go to the emergency department, that is outpatient. You got, especially if you are released to go home the same day, that is all outpatient coding. All right. What else? Anything. Thank you for the cowboy hat. Yeehaw. Okay, I'm serious now, so no more cowboy hats and stuff. Okay, but anyway, thank you for the gift. I really appreciate it. Okay, so outpatient, we got through physician office coding, inpatient, ambulatory surgery. Now, ambulatory surgery coders, it is outpatient. Okay, however, I give tiers to coding, right? I base it on reimbursement or salary, all right? So our ambulatory surgery coders are outpatient because you don't spend the night when you go and have surgery, all right? We have ambulatory surgery for procedures that maybe aren't covered in an inpatient stay, but you have to have surgery, okay? And you will not spend the night. So those coders can be either CCS or CPC, since CPC is outpatient. You can use a CPC for ambulatory surgery, all right? So physician office coders, CPC, all right? So let's see, another question, guys, you have for me, or if there's any questions out there you guys have, just put them in the chat now. I'm going to, let's see, 8:41 my time. Maybe in 10 more minutes, we're going to start teaching. I'll probably go over the guidelines again, maybe a couple minutes of them, and then I want to touch on the conventions, okay? Because it's very, very important that we understand guidelines and we understand coding conventions, all right? To be successful in this career, we do need to understand the guidelines and the conventions. They help us select the right code. Even when we're using the encoder, guys, it helps us make sure that the encoder is not taking us astray. Are you ready with your notebook and pencil? Okay, that's good, guys. I did, do I got my moderators in here? Okay, good. So I'm gonna have you guys, okay. How many people we got in here now? 10, 11. All right, so for my people here, let's see who we have. If I have any of my mentees. Hey, Amanda. Good, good, good. Fee, T said, who can become a CDI? CDI, clinical documentation improvement. Really, let's see. I've done CDI work before because I have a CDI credential. All right. CDI is primarily preserved, I will say, for our clinicians, our clinical staff, meaning our MDs, our RNs, and I'll include LPN. They know clinical, right? I see a lot of MDs and RNs, okay? Depending on the facility. Myself, I worked in a CDI role only because I worked very, very closely with physicians during when I worked with the federal government. Okay, so I did auditing and I worked very closely with physicians. So my clinical expertise is one that a clinician would know. So I've done that. So for you, if you're interested, I don't know your background, but at minimum, I would say get your LPN, all right? Know coding to the extent you understand the inpatient. You understand the coding guidelines and what coding is. You know about MSDRGs, how the reimbursement system works, okay? And yeah, that I would say I just lost my train of thought for a moment because I do want to. Okay, oh yeah, this is what I was going to say because I don't know your background. CDI, you do not necessarily have to have a coding credential. You will have to know about coding, all right? Because you may want to sit for a CDI credential. And even if you do not, because we really, like most hospital systems, have a CDI department. All right. What our CDIs do is they use their clinical sense or their clinical skills, right? Their clinical knowledge to look at the chart. And because they know coding, they kind of know they can use their clinical sense and know maybe what diagnoses could be queried, okay, to make the chart pay, the reimbursement be higher. All right. So, hey there. So I hope that answers your question. I was trying to give you a pathway to get in, right? If you don't have a clinical background, And if you are have a clinical background, what you would need as far as the coding piece to be successful in that role. Okay, good question though. Thank you. Hey, baby. Hey, Grace. Nana, see you. Define NCCI edit. As it relates to what? I don't want to be too long because that's another teaching subject. Fee. There are edits. Say if once the claim or once the account goes to billing, and if the insurance company sends it back through to the billers, right? They sometimes, before they deny it, it turns into a claim once billing gets it. When coding has it, it is not a claim. It is a chart. All right. So medical coders deal with charts. Once it gets to billing, and you see how this is a big answer for this question, and you know Tasha is going to give you the full definition. But once it comes back, there'll be, sorry guys, it's an edit. It may be an edit on it to say, and it's different edits. For example, it may be a medical necessity. The claim was sent back to billing. Billing can't do anything with these type of edits. It would have to go back to the coding department. Say, for instance, I'll make reference to one, like a medical necessity. There's an NCCI edit for that, meaning the insurance company has gotten the claim and say, okay, they see a charge for a vent. The coding, they don't see a respiratory diagnosis. Billers cannot add codes. That would have to go to coding leadership, and they would either get the manager or, an inpatient coder, outpatient or ambulatory surgery to add a respiratory diagnosis based on the medical record documentation. So I hope that helps. We could make a day where, I could take 10 minutes and really break that down or show you more examples to that. Let me know if that helps you, Fee. Thank you for the question, though. Okay, thank you for the question. I'll revisit that. You're welcome, C3. Yep, so CDI is very good, too. CDI is a very good route to go to. And I'm not going to say the good thing, but I will say the good thing is some CDIs, especially when the CDI program first started, they weren't required to have, I don't even think they're required to have a coding credential, but they are required to know how coding works. Okay. Hey, creative. Yes, please. What? Yes, please take some time to go over NCCI edits one day. I will. I'll even mods, Ambassador Fee, put in the pin, because if I don't do it here, I'll do it there. You guys know what I'm saying. Hopefully. Okay. Yeah, if not here, I'll do it there. The mods could put there, if you guys wouldn't mind. So what's good, guys? Happy Thursday. Happy Thursday. I didn't even know this was all right, we're good. Okay, thank you. Yes, it's pinned there. So if not here, I'll do it there. So make sure you guys do what you have to do there so you could get the alert when new content has arrived. Okay, so for my people in the room, if not the most important, one of the top 3 most important guidelines, okay, Well, hell, this one I say is the most important, all right? The UHDDS guideline for principal diagnosis selection. I'm just going to talk about it. I won't show, hey, little Yorkie, I won't show it here. We'll just talk through it because I want to get through conventions and answer you guys' questions. So, principal diagnosis guideline, right? We have to get this correct. You guys remember why? Why do we have to on the inpatient side? Why is it so important to get that principal diagnosis code correct? We could say, we could say two different things, all right? I'll take them both. Let me see. Let me see if you guys been paying attention yesterday. Yep, that's one. Yep, fee says payment. That's one. And this is another one. It's one more. It starts with a Q. Payment, that's very good because it definitely will dictate the payment, the reimbursement, the monies for the hospital system, that principal diagnosis, the principal diagnosis code. So the other one is quality, all right? Remember, I want you guys to, chin up, chest out when it comes to inpatient medical coding. Our profession, you guys, professions is very, very important. Yes, quality. Quality. That's very, very important. Remember, inpatient codes are stories. I like to look at, once you guys get in it and you're not even going to have to look at the documentation. That's why it's so important. Just say you will to code. Coach is not saying that. I'm just saying once you know, you're going to know. You're going to know what series a heart attack is, patient's hypertension, chronic kidney disease, all of that. You're going to know. You're going to say, is patient's hypertension, chronic kidney disease, all of that. You're going to know. You're going to say about that as we go. Not probably, I'll have a series where it's just about auditing. All right. Because auditing is a next level in coding, right? We just keep our skills going. We keep our money going and everybody's happy. But when you can just look at the code, right? You don't have to remember the whole code, but it tells a story. You may look at a chart. You may look at the audit report, even if you're looking back at your work and you're like, something's off. And you notice that it was a 3-vessel cabbage, right? The procedure. You look at the PCS, you're like, oh, shoot, I did a 2-vessel or I didn't do this, right? So it's telling a story. You're looking at it, so the quality is very important. We have governing agencies like the CDC, CMS, all right, World Health Organization. You guys will be surprised. These codes are in databases. These account numbers, this is where HIPAA comes in, okay? Health Insurance Portability Act, all of that good stuff. Patients' privacy, that's what HIPAA is. That's why these medical records are very protected. Hospital systems can get in very big trouble, all right? But the quality, I remember telling you guys, they could find out today if they put in an ICD-10-CM or PCS code, how many people in the state of Arkansas suffered or was admitted for heart attacks, all right? So say if we had a coder that wasn't maybe feeling good or wasn't on his or her game that day, and our patient had a heart attack, all right, we had a calculation that 799 people have heart attacks in Arkansas, was admitted, right? But it really should have been 800 because the coder put chest pain or something else for principal diagnosis, all right? Put the admitting diagnosis on the principal diagnosis and it skewed up the data. More than just for the hospital, right? But for governing agencies that use this data for statistics. So that's another thing. Coding is very, very, very and very important. All right. Even for our own personal stuff. Okay. I'll use me for an example. Years ago, I remember this was outpatient. And we get, we all get what they call an EOB, explanation of benefits. After you go, they'll send you this to your home and it'll say, this is not a bill. Guys, especially if you're in this profession or learning coding, look at those more than the money, all right? Look at the explanation of benefits and go to the code section. They have your codes. That's what I did. I noticed that I went for it was just like a physical. And I don't quite remember the story, but the gist of it, hey Alicia, welcome in. The gist of it was I don't even know if the physician did. This is what I'm saying. Outpatient or physician office can get very shady. I don't know if it's a certified coder coding, a office manager, or the physician themselves. But I was diagnosed with a diagnosis of obesity. Okay? Obesity. Guys, it wasn't years ago, but it was some years back where I wasn't putting on weight like that. I probably wasn't even, to be transparent, I don't think I was even 140 pounds yet. 138 maybe. Okay. But I remember talking to my primary care doctor at the time, and I was like, it's like I'm putting on some weight. And so he said, well, we'll check your thyroid. All right, now stay with me for a moment, okay? We'll check your thyroid. Guys, this is where medical necessity comes in. Physicians have to justify these tests that they're running because they get paid by the insurance company to, run tests, all right? So to justify him doing a thyroid stimulating hormone or some blood work on me, right? He had to show some type of metabolic or something that was going on with me. Okay, I talked to him about the weight. The weight, stay with me with the story. Okay, first of all, I did not like be classified with obesity. And because I am in the profession, all right, I knew that a better diagnosis would fit my situation and he would still be able to get compensated, or it wouldn't throw up a red flag for that blood work that was ordered. This is why I want you guys to know that getting into this profession is more than a paycheck, all right? Get in it for real, right? So, and right, guys, I no medical background, okay? Anyway, so I called the office up. ABC went through the spiel. And told him my diagnosis fits maybe overweight, because I know you want to get paid for this blood work that you ordered, not obesity. That's a whole nother medical diagnosis, okay? And it was changed. The code and the diagnosis was changed from obesity to overweight. I can live with overweight. I have picked up some pounds, my height with the weight, sure, we'll go with that, but not obesity, okay? And the thing is, guys, is because insurance companies, this is a way that they can rake your bill up, your rate. They look at your medical history, right? Thank you for the hand heart, guys. They look at that. That's why it is so important. And you know what? And no shade on our physician office coders. But yeah, some of that stuff needs to be fact checked. Most of the time, things are on the super bill, but we won't go into that. But if you're getting in this profession, get into the habit of, even if you're not, looking at your EOB. Make sure those diagnoses are really true, because they go with you. Like, they really do, guys. So, yep, to imagine how many codes are wrong. Exactly. Yep. Exactly. And I could go on and on, from a simple diagnosis of chronic bronchitis that the physician or the office manager put chronic instead of acute bronchitis. Chronic is different. It's telling the insurance company that you have some type of lung issue going on, not that you got acute bronchitis just from maybe some irritation, on an airplane or just out in the community. Like these are the things that we have to, I don't know, advocate for one another, especially if you're in inpatient coding, or, even my nurses just being clinical, right? We could definitely advocate for our family members. I'm not going to say our friends, but, because who wants everyone in their medical record, right? Or in their EOB, but definitely ourselves and our family, guys. Welcome in, everyone. Yes. Hey, T-Cells. What's good, guys? Hey, Lolly, I've worked in radiology for 9 years. Scary the amount of diagnosis codes are incorrect. That's right. Yeah. Yep. Hey there, T. This phone up. But yes, guys, imagine how many codes are incorrect. It's a lot. And you know what? This is why. This is why. Excuse me, guys. Outpatient. Outpatient is, remember I told you guys, outpatient coding can be coded by an outpatient coder, right? That's certified. The other thing is some doctor's office or physician office, whether they're whatever, Lolly says she was in radiology, right? They could put the codes on what they call a super bill. All right. And it'll just be all the codes or diagnoses related to that body system that you're there for. What coach is meaning is if you have a skin condition, you're going to go to a physician office that's dermatology for the skin. So their codes are everything with the skin. Okay. And who knows? They may have the office manager, the MD circling, the coder sometime. Like, who knows who's doing those codes? All right. And usually the people who aren't certified, that's what always got me. Like, really, you can code without a certification? Even if a certification, we, aren't the best coder, at least we've done our due diligence in getting what we need. I read somewhere coders have a quota to hit. A person had to hit, let me see, 2 charts per hour. Is it possible? Yeah. Yep. It's not a quota. They have production standards. You know why? Because the more you code, the more money, because it brings in the reimbursement. But yes, it's like this. I always say the manager or our leadership staff will set up a benchmark. Okay, it depends on what hospital. It's a lot of things that go into setting our production standards. All right. When I was in leadership role in our coding department, my benchmark was if the chart was a length of stay of 5 or more days, then that would count for 2 charts. All right. So say the patient was in for 7 days. When I would look at production, I would count that chart as being 2 for that coder. All right. So a mom and baby, or say a baby, right? An experience with nothing going on the baby chart. You can code a baby chart in 1 minute, right? How was the baby born, vaginally or delivery? Did the baby receive a Hep B vaccination, right? Was it a boy? Did he get a circumcision? All right. A healthy newborn baby girl is not going through nothing, just a Hep B and she's going home. A newborn baby boy, he may have a circumcision. Still, there's one PCS code for that. If the coder is smart, he or she is going to put that on a sticky on their desk to make their coding faster. All right. So you learn to be efficient. You're like, okay, if I code, I'm going to make up for my production because I have 3 baby charts. I can code them in 5 minutes. That's giving me an hour and a half. All right. Of course, if you get a trauma chart or something, even if it's not me, and you have a trauma chart, meaning the patient was in a car accident, for instance, that's a trauma. They suffered a few fractures. They had to go to surgery. They had to get some bones repaired, reposition, PCS codes. That 3 of those charts may take you 2 hours, all right, an hour and a half, depending on the length of stay. So there are production measures, guys, but no one, if you know, it's not like a make or break, like, oh my gosh, I'm not going to be able to keep up with it. Nope. We need coders, inpatient coders. So this is something that definitely is always worked through. All right. So thank you for that question. Even if you have a super bill, then you order can audit that visit, correct? Hold on. Even if you have a super bill, I don't understand. Then you order. You guys know I don't fill in too good. Y'all got to tell me the words that's right, because Coach just... Then who can audit that visit? That's outpatient. You pulling me out of my realm. I don't know. I mean, I know, but they just do what they want to do. Physician office. I'm quite sure a super bill that you can have them audit. Sorry, order the clinical note. That's okay. I would have to lean toward, I don't know, Fee, because it's physician office, it's outpatient. So if I don't know, you guys know I'm not going to make it up. So outpatient, not your girl for what they doing over there. But I know they just do stuff and circle things on that super bill. And if you're asking for an audit, yeah. I don't know if this answers your question though, Fee. So just, your girl just trying. Okay, my fear is coding fast to hit production. But what if I make a mistake? Yeah, I want to avoid that. You want to pace yourself. You're not going to... Coding is like this. Yeah, you want to hit production. Always think of it like this, okay? If somebody else can do it, that means you can do it too. All right? Coding is a skill. All right? When I wasn't able to read well, not me personally, guys, I'm just saying this is an example, okay? Because coach, you know, can read. My mama did good with sending us to school, right? We have phonics. I just want to make a point, all right? If medical coding is a skill, a highly specialized healthcare skill, profession skill, and it is, parallel it with reading is a skill. So, my point, if I give this to a pre-K or kindergartner, some of these kindergartners can read good these days. I don't know where they making these kids from. Y'all. No shade on my kindergartners that's out there learning inpatient medical coding today, but look, kindergartner, under should, so you see my point? A 5th grader, well, I'll say college, all right? Under UHDDS, should coders report every diagnosis ever mentioned in the chart, all right? That's a skill, all right? The more you do it, the quicker you get with it, the better you are with it. That's what coding is, all right? You are not expected to start coding. I don't care if you do have the certification. You're going to get some grace. Don't let that keep you guys out of this wonderful profession. You understand what the explanation that I just gave, C3? Hey, guys. What is the air in green and red mean? What's that? Thank you. Yeah, okay, good. So just breathe and pray. God, put me somewhere where the leadership staff is willing to work with me, guys. Just pray your way through everything. Prayer don't stop just at home about money, food, and health and safety. Prayer should extend to everything that concerns you, okay? even the profession. All right. Encoding. All right. Red and green. In the book, if I'm sorry if I'm messing up your name, red and green, where? In one of the coding manuals? Encoding, where? If you guys haven't grabbed your daily heartbeat, grab that daily heartbeat for me. It shows the host that a lot of love, and let's share out the live and tap. I want to start teaching a little bit or going over some stuff, but I'm really trying. Okay, we at 30. I was waiting until we got to in the 30s, so I wouldn't have to repeat. Encoding, but okay, yes. So the book, what does it say next to it? Okay, red and green. So when you look at the ending of your book, right? Don't be afraid to use your books, guys, even if they appear intimidating. All right? So I see red and green, right? And at the bottom of the page, I see red and green. So let me see. So sometimes next to codes, I'm just use your example for green really quick. Coach need her readers on. All right, bear with me because I don't see them. Let me see. Okay, hospital HAC is a hospital acquired condition. That's what HAC means in the book. A hospital acquired condition. HAC, well, no, HAC is different. HAC for this one because I'm looking at this book to see. And where's the red? Let me see. Additional character required is red with the book I'm on. Okay, so is that what you mean? Like the red check is letting you know, and I'm in the tabular. I'm in the tabular. So remember, the tabular will give you if there's an inclusion, an exclusion, or whatever. Tabular will say, this is excludes one. This code, the red here, you need another character. Okay? Okay, HCC in red here. There's what we call like hierarchical coding. Hierarchical coding. I'm in the mental and behavioral health chapter. So that's one good thing about the tabular, guys. We have to look at what I call, it's like a grid at the bottom, and it'll go in to further explain. I turn the page and I'm seeing more red. In the tabular, it's saying code first, underlying cause, if known. Right? That's in red. Code also associated mental disorder. Okay? So sometimes the color coded is just to stand out at us, right? Because if it was just all black, and still look at the bottom too. So they have let you know what the different colors mean. Oh, no. That's CPT. I have the CPT book. CPT, yep, that's CPT 6700. CPT, so you're a physician. You're already a coder? CPT, this is like this. I don't even get into CPT heavy. I get into CPT as it relates to my mentees taking the CCS or sitting for a HEMA CCA, because the HEMA credentials, they do have outpatient in there. So as it relates to using the book, what the modifiers are, and how to navigate those multiple choice questions on their certification exam. Oh, you're studying for CPC. Why is my device heating up? That's good. Congratulations that you're studying for your exam, your CPC exam. Is that correct? Hey, Jackie. So you're studying for your CPC. So this is what I will say about CPC, right? Because our CPC, physician office, I'm waiting for you to say, I'm good, Jackie, how are you? So yes or no? Who's asking to come up? Okay, let me see. I'll let you come. Yes, you haven't.
Hello.
Yes, hey there.
How you doing?
I'm good. How are you?
I'm good, thank you.
That's good. What's up? What's your you? So you going for CPC, right?
Yeah, CPC.
Okay. So we do. Well, I primarily do inpatient in here.
Okay.
Um, Inpatient coding, how it relates, medical coding as it relates. I probably didn't. So the only thing with CPC, just to give you advice on it, not the exam per se, but only because AI, all right? AI
Mm-hmm.
is here, not coming. And a lot of the AI, a lot of the physicians are replacing coders or the coding responsibility to artificial intelligence because it's a lot, it's more efficient. That's why businesses are getting AI models. So here I try to let you guys know that if you are going for CPC or learning that, that is great. Just learn inpatient as well. So all the hard work that you're putting into understand coding, because you are learning ICD-10-CM, so that's a good thing. But still kind of learn PCS as well and inpatient guidelines so that you don't lose everything and get frustrated, not when, but not if, but when they replace the physician office coding for AI. All right. And they don't
Okay.
tell you that these programs that you're going through, babe.
I mean, I already finished. To be honest, I studied for 10 months through Dubai,
Uh-huh.
and I'm studying for my exam, and I just not understanding what the errors are. For example, it will say 76,380, and then on the bottom it will say CPT change an insider view 2002 and 2003. Like
Uh,
it has a different color, so that's why.
Yeah, I understand what you're saying too. And DeVry charges a very good penny for you not to, you don't have resources to reach one of your instructors with DeVry for CPT.
What do you say? I'm sorry.
No, that would be a good question to sit with one of your instructors. I know you're on the live just to ask the question, but make sure that they give you everything that you signed up for, and that's to try to understand the CPT.
Okay.
All right. Thank you for your question, and hopefully this live will help you. And have a great day. Good luck in
Thank
your
you.
coding studies.
Thank you.
You're welcome.
Bye.
Oh, you sent me? Okay, Manda. All right, I'll look. If I don't get to it tonight, Manda, I'll look in my DMs tomorrow. Thank you for jumping on. Yeah, those small letters are citations. CPT, I did outpatient my first couple months, and that was years and years ago. I did not like CPT coding, right? And then I looked at what the coders made with that credential. So I'm like, nope, that's not enough compensation for that. But some people love CPC and getting into that CPT book. I would much prefer the inpatient procedural coding. At the time, we had I-9, and I thought I loved I-9. However, when ICD-10 came out, and I'll go through, right? the PCS system, it's better than I-9. It is logical, it is tables, it is so much better, guys. So, and then you get compensated for the work that we have to do. Let's see. So I went to a school today that has a medical billing and coding program. You did? I'm doing good. That's good. All right. Okay. I'm just checking to see if I had any questions as it relates to inpatient coding. Okay. All right. So my people that's in here for inpatient, let's get to it. I'm going to ask you guys a couple questions, and then I want to go review conventions. All right. We're going to look at some conventions. So you guys know we talked about UHDDS. Payment is very important for payment and quality. Okay. What are the two main places in ICD-10-CM that coders must use to find the diagnosis code? So when we're using our books to find the diagnosis code, let's go with this. What's the first place you want to look in the ICD-10-CM? All right, I'm asking chat. So what's the first place, guys? So I see if I want to go through this. Okay, the two places, good job. Index and the tabular. Right. Good job. Good job, Alicia. Good job, Tammy. Alphabetic. Right. You guys answering both of them. Right. Index. Okay. Yep. Very good. Very good, T-Cells. I see you guys. What? Okay. So that's the part B. Alphabetic, index, and the tabular. Yes. Okay. ICD-10-CM codes are alphanumeric, all right? And they can be up to how many characters long? Good job. What? 7. Very good. Yep. 7. They can be up to 7. But they must be at minimum 3. Very good. Very good. Yep, very good. Yep, 3 to 7. They can be 3. That's the category. 1, 2, 3, period or dot, whatever you guys want to call that, dot, period. But 3 goes before the period, just in case you see it. It could be on an exam for your career opportunity if you get a test before you interview or after, or it could be on the certification. ICD-10-CM can be up to 7 characters long, but it must be at least 3. Very good. Okay, let's see. I'm not going to ask you guys anything about conventions because I'm going to run through them tonight. Okay, this is conventions. I won't do that. Okay. In the inpatient setting, Coach said it twice for a reason, can uncertain diagnoses such as probable or likely be coded if they exist at discharge? Yes or no? Again, in the inpatient setting, can uncertain very good. Yes, Holly, yes. In the inpatient setting, uncertain diagnoses such as unlikely, probable, suspected, these can be coded as if they exist. The caveat here is inpatient setting and at discharge, meaning the final or last progress note okay, or the discharge summary. Very good. For the most part, good. And there's, I love the engagement, guys. So just tell me what you think, and I can address it and correct it if need be. Very good. So therefore, let's piggyback off of that. In the outpatient setting, okay? In the outpatient setting, what are you coding if a patient comes in and out the doctor's office and they come in with a fever, shortness of breath? All right. The doctor says suspect pneumonia. You're in an outpatient setting at the doctor's office. As an outpatient coder, whether it's on a test, certification, what are you coding? Yep, signs and symptoms, signs and symptoms. Very good. Signs and symptoms. Very good. Very good, guys. Let's see. Maybe one more. Let's see. Okay. All right. Well, we talked about this. I guess I can ask it. Okay. Name one reason inpatient coding is vitally important. Wait before you wait. Beyond just getting paid. Coach talk about the money all the time, but beyond that, name one reason inpatient coding is vitally important beyond just getting paid. Very good. Statistics, and it's the Q one. Yep. I don't. Wait, somebody said, but not these, but I've been starting to I guess I can say record. I just won't mention anything about YT. But yes, yep, data, statistics, quality, all of that. Yep. Very good. All right. All right. All right. Guys, I can't wait to start PCS. PCS, it will take every day for a minute. And that's probably why I haven't. Because all of my next questions is about PCS. You guys know the extent probably of PCS that you guys remember. It said it's a 7-character code set. Now, PCS ain't 3 to 5 or 6 or anything. It's 7. But we'll talk about, I'll ask questions about PCS once I go through it. Okay, so we did UHDDS last night, and we went over some questions the night before. I was looking at this right here that I had, guys. Let me just share this really quick. And this is really nothing like that. It was just, let me turn this on. Thank you, Fee. Yes, guys, go and handle what is pinned up there, because then you'll be able to kind of do some binging. All right. Remember we talked about UHDDS and these buckets. I just wanted to show you guys kind of like for anyone who hasn't quite, seen a medical record. Not that it looks like this, guys, but all hospitals, I was going to say the majority, but all of them, you'll have a medical record number. Where's my little pointer? Okay. So we'll have, patient demographics. I just really want you guys to be saturated. And if you're thinking about this career, pivoting or starting inpatient medical coding, it is really, really, it's a skill. So you guys pick it up. That's why we go over stuff that I don't even think is relevant, but I remember teaching and just how if you don't know and you haven't seen it, it really helps you, okay? So when we were talking about UHDDS, we talked about 4 buckets, all right? And so this is how the payment is calculated too. We don't calculate it, but the hospital system has a background way, and they look at parameters like this. They're looking at the patient's age sometime, the admission, the length of stay. You'll see discharge date, admission date. That's how we get 2 days length of stay. LOS is length of stay. We have admission, we have discharge, we're going to have the patient's name, we're going to have the patient's age and sex, and this means a lot, right? Because sometimes if you're in the encoder and you have, for instance, you're looking up a male diagnosis, say you're looking up BPH, right? Benign prostatic hypertrophy is what that stands for. And you happen to have that the patient is a female, you will keep getting an error message or can't find that code. So these are just little tidbits that, coach just randomly talks about sometimes. So if it applies, it's good. And if not, we'll just say it doesn't apply right now. So chief complaints, primary, all right upper quadrant, abdominal pain. We see a secondary chief complaint, acute kidney injury, past medical history, which is your PMH. We see hypertension, right? This is the abbreviation for hypertension. We see type 2 diabetes a lot, DM type 2, DM2 or 1. Patient is on metformin, all right? So it's being treated. This hypertension is being controlled on lisinopril. That is a hypertensive agent. All right, remember I told you in inpatient coding, we always refer to the ED or the emergency room, emergency department record, because that's where we'll pick up why they came, why they presented to the hospital for care. Okay, 58-year-old female presents with acute onset right upper quadrant pain. Her pain was 8 out of 10 after a fatty meal. The pain radiated to her right shoulder, all right? Associated with nausea and vomiting, that's what N/V means, times 3. Labs show a WBC, which is a white blood cell count of 15.2. Her creatinine was 1.8 elevated. Guys, don't let this throw you. This has to be in the chart because it's more than inpatient coders in the medical record, all right? Even when you're doing auditing, there are certain things that an auditor in the coding department would look at, okay? Ultrasound, so here's our after study. Ultrasound confirms multiple gallstones with a positive Murphy sign. AKI attributed to pre-renal cause, okay? Dehydration from vomiting. I know that looks like a lot, but it still goes back to what Coach said. Why did they come through the emergency department? Right upper quadrant abdominal pain, period. All of this is cool, but right now you don't have to look at this. You can read it, but I want you guys to know so you don't get, just frustrated or confused when you get these medical records, when you look at them. You're looking to see why they presented, and after study, what did they find? And then you're going down to the physician documentation to see what diagnoses or what documentation they put, okay? So this is just, like I said, I just wanted you guys just to see maybe what a potential chart would look like in some electronic health record. Okay, ED arrival, here's the date and time. Patient presented with right upper quadrant pain, all right? You see AKI. Admitted, H&P, we see acute cholecystitis, okay? This is how they managed it. So you see the patient was nothing by mouth, IV fluids. They did a laparoscopic cholecystectomy and patient was discharged, all right? Patient presented with abdominal pain due to acute cholecystitis. I think the patient also had cholelithiasis. Okay, but they did a laparoscopic cholecystectomy. So after study, the patient had gallstones. So would you code the right upper quadrant abdominal pain? No, because that was a symptom that was part of a definitive diagnosis, okay? So you would not code abdominal pain at all unless the physician documented that there was no cause or no etiology. You'll see terms like that. That's the only way. After study, we don't know why the patient came in with right upper quadrant pain. Okay, so that was that, guys. I had pulled that up just to talk through that for a moment. But I wanted to... Okay, how are you guys with the conventions? Because I was just thinking, let me see who's in the room. Because I could probably upload this too. I just want to see, okay, 21 PCS book. You can also take a free PCS small class under CMS website. Okay. How are you guys with the conventions? I'm getting more familiar with the guidelines than I am conventions, as we don't talk about them, okay, that often. Okay, so I can go through the conventions a little bit. Extirpation. Okay. Need to practice conventions. Okay, so I will. I'll go through the... Okay, good. Okay. Good. All right, so we'll talk about the ICD-10-CM conventions for about 5 minutes, guys. So that'll be good. Hey, Tasha T, come on from the beginning. You guys know I can't be putting stuff together. Extirpation. So, extirpation is a PCS root operation. I promise to get to PCS. You guys have me here. Let me just... guidelines, conventions, and then I'll bridge into PCS. I just know once I start that, I'm not going to be able to let PCS go. But you can go over to when you pin the YT, you go there, because I'm definitely going to start that series. Oh, for removal, they said a laparoscopic cholecystectomy fee. Okay, so the approach, remember, extirpation, let me see. Okay, so remember your approaches. Look, Fee's pulling me into PCS really quick. And because I really I love Fee, guys. So look, I'm going to show her something really quick. Of course, these are the flashcards that I want you guys to, well, they're a good tool, all right? Let's see. Extirpation, laparoscopic cholecystectomy. The approach is laparoscopic. So that means they used a scope, right, to visualize that body part. Percutaneous endoscopic. Okay, extirpation. Let's look at the definition of extirpation. Taking or cutting out a solid matter from a body part. And Fee, I know you have these. Extirpation. And they did take or cut out a solid but matter. You see, matter. So you see that thrombectomy, that's a blood clot. Taking or cutting out a solid matter. So the intent, your root operator is asking you, what was the intent of the procedure? The intent of a thrombectomy, when you just look at that, the intent is to remove a solid matter, which is a blood clot. All right. Now, a laparoscopic cholecystectomy, we're dealing with a body part. All right. So that's where we're going to look at our root operator. Let me pull it up on the card, guys. I have, okay. Oh yeah, it's not approach. We're looking at the root operator. I'm sorry about that. So excision or resection. Did they take out the whole gallbladder or a part of it? Because they're removing a body part without replacing it. So right then and there, we're down to two: excision or resection. Did they take out the whole gallbladder or a part of it? But these are body parts. The gallbladder is a body part. The difference with extirpation, they took out a solid matter, like a blood clot would be. Right. Extirpation, good. T-cell removal of a solid matter. Okay. Right. Okay, resection. That's good because they took out the whole gallbladder. So our root operator would be resection for that cholecystectomy. So you see that now, Fee? That it wouldn't be extirpation because that gallbladder is more than like a blood clot. It's more than a solid matter. It's not matter at all. It's an actual body part. So that's why I want you guys to really hone in on your 31 root operators, okay? Because usually the error code on PCS is with the third character, which is the root operator. And these cards are very nice even to stick in your purse if you're a guy out there, you know, or don't carry purses, even if you're not a guy. Some women don't like purses, but maybe, you know, everyone goes to the bathroom, I would hope, right? So maybe in the bathroom, you know, maybe for 3 minutes, is sitting next to the commode and you could just go through some of the heavy hitters. And you'll be surprised, right? The more you look at it. Okay, yes, I misunderstood the question. I thought they removed the gallstone. Oh, okay. Okay. Yeah, they did remove the gallstone. However, they decided to remove the gallstone because they were inside the gallbladder. Right? You know, sometimes those gallstones, they're like different size marbles inside the actual body part. So in order to remove the gallstone, if they just don't come out themselves, sometimes if it's a lot of them, they'll just say, hell, we have to remove the whole body part, the whole gallbladder, because we have 20 marbles sit inside this patient's gallbladder, causing all of this pain and indigestion. So it's just easier to take out the whole gallbladder. But I understand, you know, I understand your extirpation now, if you thought that was it. All right. All right, guys. So was that good? Even sometimes there are some stones left behind going towards the liver. That's right, C3. There are. We ain't talking about we're not bringing up no clinical, all of that. But yep, there sure are. And sometimes people can come in, yep, they left behind. And there's a code for that. The PCS book also has the root operation, yep. Okay. Okay, good example. All right, let's look at these conventions now, guys. I promise we're only doing the heavy hitters, so you guys have heard them before, so I know a light bulb will go off and you'll be like, oh yeah, all right. So let's get to it. All right, ICD-10-CM medical coding conventions. So along with the guidelines, we have what we call the coding conventions, all right? These are very important because they do help us select our codes more accurately, all right? So let's go through 1, 2, 3, 4, 5, 6. Let's do these 6. There are other ones like see also, but I didn't put them, guys, because that's kind of self-explanatory. See also, you'll see that in the tabular list, and you'll know it'll say see also, and it'll list a code or a diagnosis to see also, and you'll go and see that also, okay? Or use additional code. So those are conventions, but those are the ones that if you guys will probably agree, but those are self-explanatory. You know, sometimes these are too once you get them, but you do need them explained a little. So NOS, not otherwise specified, equals unspecified. Doc didn't give detail. The physician did not give detail. All right. NEC, and we'll go down to examples later. NEC, not elsewhere classified. Just know what NOS means. That's the caveat here. NOS, not otherwise specified or unspecified. NEC, not elsewhere classified or other specified. The doctor gave detail, but there's no exact code for it. Our brackets equals show extra info. So in the index, all right, they flag a manifestation that's coded second. Parentheses equal non-essential words. They don't change the code. And I'll show you guys this in a minute. Excludes one, never code these together. These are mutually exclusive, never together. Excludes two, they're okay together, code both if documented. Okay, so let's get into it. NOS, not otherwise specified. NOS used when the note is too vague. So for example, the note just says pneumonia. That's it. You do not have to query the physician for something that just says pneumonia. All right. That's an unnecessary query or question because the physician had already said pneumonia. Okay. Now, say if you are, I'm going to say CDI. All right. And you see that I'm going to say more than a sputum, but you see that the test came back and the pneumonia could be MRSA or MSSA, Staphylococcus. That's a different code, right? And a different DRG. So in that case, something would be queried. For this sake though, NOS, if you just see pneumonia, we're just going to code J18.9, pneumonia, unspecified organism. All right, unspecified organism. That's all the doctor said. When we go back to NOS, it equals unspecified. NOS, not otherwise specified, equals unspecified. So the note says just pneumonia. It's unspecified. The organism is unspecified because the note just says pneumonia. D64.9, anemia, unspecified. The note says anemia, no type. No blood loss anemia. No pernicious anemia. Okay? And you guys don't have to know the different types. Just know if you got a note that says anemia and that's it, it's unspecified. If you have a note, the documentation says acute blood loss anemia, then you would index anemia, go down to blood loss and acute and code that. Right now it's D62. But if all the note says was anemia, it's unspecified, D64.9. Oitis media, unspecified. All the doctor said was there's an ear infection. He didn't say what ear, right or left or anything. 9 times out of 10, we are not going to query for laterality. Laterality means the left side of the body or the right side. Okay. Oitis media unspecified. However, usually oitis media is going to be a secondary diagnosis, but say the baby or anyone came in with an ear infection and they had to put ear tubes in an inpatient setting, you best believe in that odd report or somewhere in that medical record, you're going to have laterality. It's going to say we put the right ear tube in or we did the left. So don't even worry about why, or why wouldn't I have to query, coach, or wouldn't they want to know if it's right or left? Oh, it's going to be there. Okay. But if it's not there and you just see ear infection documented, this is just a secondary diagnosis too. It's not a CC, it's not an MCC. So it's just a secondary diagnosis code. You just want to code it, ear infection, and move on. All right. Like I said, if this was going to be a principal diagnosis, all right, patient admitted with ear pain, they have a severe ear infection. The medical term for ear infection is oitis media for this type of ear infection. Trust me that if they go to surgery, you're going to have laterality in that OT report, meaning it's going to say right or left. You can capture laterality from different parts of the chart. Okay, NEC, not elsewhere classified equals other specified. Okay, NEC, doc gave a specific description, but the book doesn't have that exact one. Use an other code. So the other codes usually end in 8.8 or 0.89. Okay, you see nines here, usually are unspecified, will be 0.9 at the end. It's nothing that you're going to get a question about, like, what does unspecified codes usually end in? All right, so don't worry about it. This is just because you know coach, and I just tell you guys probably a little more things that may take you longer to pick up. You know, you be like, oh, I did notice this, 4 months into my profession. So I'm just, bringing out talking points, guys. Okay, NEC, other specified 0.8, 0.89. Examples for NEC. The doctor writes a specific dermatitis not listed by name. So I remember saying you get the note and you're in the chart and it says googly dermatitis. Itis, inflammation of the skin. Anything with derm is the skin. Itis is inflammation or an infection, okay? So our doctor wrote googly dermatitis. You go to the alphabetic index, you look up dermatitis, you're looking for googly, but you don't see googly. Does that mean is you just default to unspecified dermatitis? No, because that's not accurate. The doctor did say a specific dermatitis. The classification does not have googly. So therefore, this is when NEC comes in at. It's other specified. Okay, so the code would be L30.8 for other specified dermatitis. You guys see that? Okay, let's see, go down to the next one. Abnormal level of other serum enzymes. The doctor stated elevated amylase. No listed code fits exactly. So we're just doing an abnormal level of other serum enzymes, okay? R78.9, all right? And we have some more specific ones. There's enzymes for troponins and different things like that when you look in the alphabetic index. J84.89, here's an other specified code. Other specified interstitial pulmonary disease. So if you see in the documentation, the doctor could put a rare ILD. All right, a rare interstitial lung disease. Off the top of my head, I can't think of a term that's classified as a rare, but it could be something new that they haven't added to the index yet. All right, so we still have to capture diagnoses, and we would capture a definitive diagnosis, right, that wasn't unspecified, but the doctor did specify it with an 8.9, other specified. interstitial lung disease. Well, pulmonary, I said lung, guys, my bad, but pulmonary is lung. Okay, so this is how I want you guys to contrast or put them next to each other when you're looking at it, okay? NOS means not enough info is in the note. NEC says plenty of information is in the note, but there's no precise code, all right? So usually 0.9 and usually 0.8 or 0.89. Plenty of info in the note. NOS, not enough. So let's move to our brackets. Brackets do two things. In the index, meaning the alphabetic index, bracketed codes are manifestations that you code separate. Second, let me close this up, guys. That you code second. In the tabular, which is the second part of the ICD-10-CM book, brackets can show synonyms or explanations. So for example, this is an index example, and this is more likely where we see it at. Parkinson's disease with dementia. All right. Code the cause first, which is the Parkinson's disease. Then the dementia second, F02.80. Brackets signal the second code. You see how that looks? So in the index, you're going, you can just straight go to Parkinson's, okay? And so you're going to get a code for Parkinson's. Then there's sub-entries, sub-terms, because Parkinson's may have different manifestations, okay? In this case, the dementia is a manifestation of Parkinson's, meaning it comes, in this case, the patient has dementia, but it's from Parkinson's disease. So that's requiring two codes. The sequencing goes like this. The Parkinson's, which is the etiology or what caused the dementia. The etiology goes first. The manifestation is coded second. In the index, we see the manifestation in brackets. Now, I'm going to say this. There's only one place to put the principal diagnosis code, all right? So if the patient presented with altered mental status and they diagnosed the patient with dementia, and the note said the dementia was due to the Parkinson's disease, this is where this convention would come in. We're dealing with principal diagnosis here. We're going to code G20 in that principal diagnosis spot, followed by F02.80 for the dementia. Now, if the patient presented with shortness of breath due to pneumonia and the patient also has Parkinson's with dementia, it doesn't matter the sequencing because that pneumonia is going to go PDX, patient presented with shortness of breath. The reason for inpatient admission after study was the pneumonia. That's principal. Now, when you get to coding hypertension, diabetes, all of that other stuff, Parkinson's, dementia, it's going to be there. But say if you put G20 for your fourth code and FO2.80 for the seventh code, they're still coded. They're still on that account, all right? So it matters, but it doesn't matter because once the grouper gets to going, it may not even keep these two codes together, right? So, but it will make a difference, guys, when you're coding that principal diagnosis. All right. In the example I gave, and we'll go through this again. This isn't the be all, and I'll probably go and do something on YT for this. So if you don't get it, you can, do that. Maybe moderators can put it in the pin that. Okay. So here's a tip. When you see a bracketed code in the index, think secondary or manifestation, all right? It comes after the primary condition. So primary condition here was Parkinson's. Dementia is the manifestation or the second. Parentheses. Words in parentheses are non-essential modifiers. Whether they're in the note or not, the code stays the same. So when we look in our index books, alphabetic index, say we're looking up pneumonia. Next to pneumonia, we're going to see non-essential modifiers inside of these parentheses. It's going to say whether the physician said acute pneumonia, it's going to the same code. If the physician said double pneumonia, it's going to the same code, J18.9. If the physician documented migratory pneumonia, it's going to the same code. So these are non-essential, which means it doesn't have to say acute pneumonia. It doesn't have to say double. It can just say pneumonia. But some physicians, you know, depending on when they got their medical license or, you know, what they want to say, right? They're definitely more clinical than us. So they don't, the index doesn't want us to get so like, oh my gosh, you know, so it's certain things that are non-essential modifiers. Okay. It doesn't have to say it to get J18.9. But if it does say acute pneumonia, it still goes to J18.9. Where the code shifts is under those subterms. Say if you're in the alphabetic index, for those of you who have your books, and their subterms under pneumonia, like, okay, COVID with pneumonia, viral pneumonia, staphylococcus, streptococcus. There's certain different bacteria that could lead to certain pneumonias. So if the doctor did document the type and it's a subterm, coach is saying, yes, you want to follow the subterms. However, non-essential modifiers, if it's in parentheses, it's basically like, don't worry about it, because it's still going to get J18.9. All right. Hopefully that makes sense, but maybe when you guys come to it and see it, all right, and then you can go to the video again and watch it. Okay. So another example was fracture. What type of fracture? Radius. All right. Shaft and close are in non-essential modifiers. Are in parentheses. I'm sorry, guys, and they're non-essential modifiers. Those parenthetical words don't change the base code choice in the index. You don't even have to know what a shaft fracture is, okay? The physician has documented the type of fracture or the location, fracture, radius. Okay, he could say or she could say close. It doesn't matter. It's going to the same code, and I don't have the code listed here. But the point of the matter is the parentheses are non-essential modifiers. Here we go. Excludes one, not coded together. Excludes one, never together, but pick the right family. So example, essential hypertension has excludes one note over in the tabular. All right. These diagnoses are in excludes notes. Excludes one. We don't code. I say essential hypertension as just regular hypertension. All right. I wouldn't code if the physician documented, say for instance, hypertensive heart disease. So you wouldn't have a code of I11.0. I wouldn't code this with I110. Why? Because in the tabular list, it's going to have an excludes one for these codes. I11, I12, I13, I15. All of these are hypertensive. This is hypertensive heart disease, hypertensive chronic kidney disease with code to I112. All of these hypertensive heart and chronic kidney disease, secondary hypertension. All right. It may sound like a lot, guys, but it's simply saying this. If you're coding hypertension and you're like, okay, I coded hypertension, you could code it, but then maybe you're going to find the code for hypertensive chronic kidney disease, and so you coded I112, but you notice it's an excludes one note saying no, no, no. Under here, don't code, pick which one, pick the right family. It's either one. Okay, and you always want to include the combination code with hypertension if you have the documentation. Okay, So again, here, if there's heart or kidney involvement with the hypertension, don't use I10. We're going to move to I11 through I13. Excludes one means not here. So just remember that, guys. Excludes one means not here. Never code these together. Excludes two. You can code both if documented. So excludes two equals the condition is not included here, but it can coexist. So code both. Okay, so one, don't do it. Two, we can. So excludes two, look at this. COPD, which is chronic obstructive pulmonary disease, and asthma. So J44 is the code for COPD. It's the category, okay? Because we have a point and this hyphen, so we need another character. All right? Whether it's unspecified with acute exacerbation, something like that. All right? So J44 COPD has an excludes 2 for asthma in the current ICD-10-CM. So the note says you can code both. All right? So you can code COPD and you can code asthma. Acute kidney failure with chronic kidney disease. N17 is the category for acute kidney failure, and N18 is the category for chronic kidney disease. There's an excludes 2 which says you can code both together when the note says acute on chronic, all right? So we would not look at this and say, oh, our patient has acute kidney failure, so I don't have to code the chronic kidney disease because it sounds like acute is worse, all right? No, these are two clinically different diagnoses. A patient can go into acute kidney failure and still have chronic kidney disease, okay? And I'm not a doctor, guys, so let me just put the disclaimer out. I'm not giving medical advice or anything. This is all for education purposes only, okay? My own clinical experience or my coding experience, no information given, all right? Just my disclaimer for the platform. So I was going to say dehydration can lead to acute kidney failure. So a patient can have like chronic kidney disease stage 3 and acute kidney failure if they've maybe been vomiting or dehydrated for a long time. They come into the hospital dehydrated, all right? Oh my gosh, the patient is in acute kidney failure, okay? And they could have chronic kidney disease. You guys see how excludes 2 would work and why we can code both? All right, excludes 2 equals not part of this code, but it's allowed. Add another code. So Doc just wrote pneumonia. Is that NOS or NEC? Coach put the answer right here. Doc just wrote pneumonia. Is it NOS or NEC? Answer is NOS. Doc wrote rare interstitial lung disease, not listed by name. That's NEC. Index shows G20 with brackets around FO2.80. Which one is coded first? We're going to code the etiology, which is the Parkinson's, followed by the dementia because it's in brackets. All right. COPD with asthma, code 1 or both. Answer, both. Excludes 2 allows it. You will see the excludes 2 in the tabular list, guys. Okay, let's do this. Hypertension with chronic kidney disease. I skipped this one. Can I use I10? With hypertension with chronic kidney disease, can I use I10? No. There's going to be an excludes 1 that pushes you to I12. So that's why it's important to understand your coding conventions, and you will see those in the tabular list, guys. That's why it's important to not only just get your code from alphabetic index. Please always verify in the tabular, because the tabular will tell you if it's excludes 1, if you should see also, if it's sequence and direction and things like that. All right. So I'm going to end it here, guys, but I will do this and put it on YT for you guys so that you'll have that as a reference. How was that? Give me a 1 if you guys understood that. Was it a good refresher for those of you who have heard it before? It's 10:10, guys. We're going to be... Thank you so much, Coach. You're the best. Oh, 111. Good job, Holly. Luna, 1. Good. Free 1. T-Sales, good. 1. All right. All right. Good, Tammy. Good refresher. Okay. All right, guys. We have made it to the hour. We did good. So I want you guys to retain this stuff. Not a whole lot of information on the live since it's more frequent now, but parts, okay? Take your notes. And like I said, I will reenact this and on YT for you guys to look at and just refresh or take notes or whatever. Let's see. Any more questions for Coach tonight before we head out? Tomorrow is Friday. Let's see. We'll go. Let me see. What do I want to do tomorrow? Trying to give you guys a heads up. I'll look at my questions and see what I can pull out tomorrow because I always get requests. And so I'll see if it's following in the line to be a good place to piggyback off of what we were talking about this week. But definitely let's start. Next week is spring break. I'm still going to be here, guys, regardless of where I am. So I'll still be here. I was thinking about starting PCS next week. Good. Yep. Thank you, Fee. Let's see. Okay. Oh, yes. Yep, Kendra, it is chapter 15, chapter 15, which is OB, but not perinatal. Chapter 16 still have to do, but chapter 15 is on YT. Thank you. Okay. All right, my lovely people, I think I have cleared the questions out the room. Thank you guys for joining me tonight. Thank you guys for giving your feedback. I'm so proud of you, even for answering the questions with the UHDDS Principal Diagnosis Guidelines, guys. I'm on vacation next week and I take my exam on Tuesday. Lots of studying this weekend for me. Yes, you already got this. Thank you, Ambassador. You got this, Nicole. Go over your guidelines, breathe. All right, and read. Right, read. Believe it or not, I know the organization wants you to get your coding credential, okay? So it's not a trick question. It's just seeing if you understand a base knowledge of the guidelines, are familiar with using your books, and process of elimination. All right. If I can give any advice, if I don't see you or talk to you for multiple choice, do your process of elimination. Okay. And sometimes make educated guesses. Some of those questions, guys, are questions that they throw in that they know you're not going to have the answer. They'll just put them in there, right, to see how they can do the next test or where the population is. So if you read something, you're like, oh my gosh, I'm not prepared for this test. What kind of question is this? Know that Coach said it may be one of those questions that is just thrown in there. All right. So be kind to yourself, Nicole, or anyone out there taking the certification soon. Get up on your guidelines, breathe, pray, not in that order, but pray, breathe, know that you got this. And yeah, I started watching, and it's really, oh, that's good, creative. Okay, good. So I'll make sure that you know, you guys are supported over there. Okay. I know, yes, come back either way, because that's only one step. That's only a stepping stone for our certification. I know the blueprint is for that, but I want you guys to know that, you know, I'm here, even past that. Yep, even past that. All right, guys. Well, if there's anyone in here, I need to offer, if you are wanting to get in the profession or pivot, I invite you to the link in my TikTok bio to get started with the blueprint. Other than that, guys, you know where to find me. Thank you so much for joining me tonight. Thank you for the likes, the taps, the shares, the questions, the input, right? The laughs, all of it. I appreciate you all as usual, and I will see you tomorrow, or when you join me. I will see you. If not, have a good weekend, guys. Have a good holiday if you do celebrate the holiday, and I'll see you guys tomorrow. Good night. Good night. Good night. Good night.